Good afternoon, everyone, and welcome to this meeting of our Council of Governors at Chesterfield Royal Hospital. I'm Helen Phillips, and I'm the Chair of the Trust and the Chair of the Council of Governors. It's a meeting in public, and we always welcome comments in the facility to raise questions or comments, and we come to them at the end of the meeting. Should there be anything that colleagues joining the meeting would like to explore with the council. So a very warm welcome to you, and an opportunity and an invitation to participate in that way. We've got a busy agenda today, and we will initially note apologies. If I could go to John for them, please.
Yes, we have apologies from Deborah Watson, Florence O'Connor-Reid and Mark Couple and Nick Smith.
Thank you very much. And that brings us on to declarations of interest. Are there any changes to the register of interest or any declarations that need to be made with respect to today's agenda? Norman.
Yes, Helen, I'm no longer a director at Chesterfield Golf Club.
Thank you very much. I'm sure that isn't keeping you off the fairways.
No.
But we will amend the register accordingly. Thank you, Norman.
Thank you.
And then we have at this point no questions from the public, but as I've indicated earlier, we'll revisit that at the end of the meeting should any arise, and in which case we'll go directly to item 4, which is the Chief Executive's briefing. So the floor is yours, Hal.
Good afternoon, all. Just in case anyone doesn't know me, my name's Dr. Hal Spencer, and I'm currently interim Chief Exec. Prior to that, you'll have known me as Medical Director. For the Chief Exec's report, which hopefully you've got, there's some things that I sort of draw out from that. I think I'd start with the really quite extreme operational pressures that the hospital has been under over the last 2 or 3 weeks. Some of you will have been aware that we, particularly over the run up to Easter and just after Easter, we had a very challenged period with a combination of higher than previously COVID numbers. Worth mentioning that the patients with COVID in the hospital, the vast majority of them were not desperately sick with COVID, but they were in hospital with COVID, and that has very significant kind of operational issues about how we manage patients with COVID and have to isolate them from other patients in order to protect other people who are vulnerable in the hospital, and kind of allied to those high COVID numbers, very significant amounts of staff absence related to COVID. So again, even though a staff member might not be particularly sick with the COVID, they aren't able to come into work if that's the case. So our staff absence normally runs at about approximately 5% overall. In that period, peri-Easter, we were above 10%, of which slightly more than half of that was related to COVID absence. So the combination of those two things, and then combined with very high activity coming into our emergency department, significant pressures about being able to discharge people related largely to the social care and care home places, and to be absolutely fair to them, real challenges for them as well, because of course, for example, packages of care in the community, the people delivering that care in the community also had high rates of COVID themselves, and if they had COVID, they weren't able to look after patients, and exactly the same thing in their care home. So there was a real challenge around that period, and there was as a result quite a lot of, in a positive way, good system discussions around that, so including our local authorities, so not just healthcare, about what could be done to alleviate some of those pressures. So just to reflect back on that, of course, we've sort of emerged a little bit from Easter the other side, and things are a little bit easier than they were. The hospital's still under significant pressure sort of today as we speak, but it's not quite as bad as it was a couple of weeks ago. Alongside that, I'd just highlight in the report So it is really challenging, but actually our emergency department continues to do a fantastic job, and the report's written in a slightly negative way because it talks about our 4-hour targets decreased from 4th down to 8th, and a decrease always sounds bad, but I think the bit I'd be highlighting is that actually throughout that last year our emergency department's been in the top 10 trusts in the country, and we should all be proud of that, and we should be congratulating what they managed to do in ED. And as another kind of reflection, one of the things that NHS England and the country is really focused on at the moment is, thank you, applause there from Helen. So I think one of the things NHS England is really focused on is about ambulance handover delays. So to give you a perspective, and that's been in the news, in March, the whole of March, I think we had just 2 or 3 handover delays more than 60 minutes at our hospital. In comparison to that, Leicester had over 2,000. So when we hear about some of these things in the news, there's a completely different scale of, and Leicester is a bit bigger as a hospital, you know, it's about twice as big for numbers coming in, but even so, I think we just need to remember that in difficult circumstances, our teams are doing a really good job sometimes. So that's the sort of operational bit. There's bits within that about elective recovery, and that's in a way where we're all sort of moving in a way in this kind of post-COVID era to, you know, what can we do to recover where things have really slipped? Because you'll all remember a couple of years ago before COVID, we'd been really disappointed and shocked if we had patients waiting more than a year to get treatment, and the whole ballpark has moved, because now NHS England only talks about 104-week wait, so we're talking about two-year waits rather than 1-year wait. We believe that we're on a trajectory to not have any 104-week waits by July, which is the national kind of required target, if you'd like. There are some challenges around that, and obviously things like Easter that's just gone puts in a further challenge, because we had to stand down some elective operating over that period, which kind of makes the problem bigger again. But we feel reasonably confident that we'll have addressed it by July. That's very unlikely to be the case across the country, but locally we believe we'll have done that. Now, obviously, where we want to get back to is the position where people aren't waiting a year, and there's a lot of work still to be done with that. I mean, waiting a year is a long time, isn't it? So I don't think that's our kind of real aspiration, but that would be, at least getting back to where we were, would be a much better position. So there's lots of work to do with that, but equally the teams are coming up with sort of realistic and robust plans about how we can do that, and I'm confident that the situation a year from now will be a lot better than it is now, providing there aren't any other completely unforeseen, you know, new pandemics or, you know, whatever it happens to be. But I feel confident that we've got that in hand. A couple of other things to mention. You'll have seen there's changes about infection control and the regulations. So just this Monday, we've put in place the new national guidance. So, for example, the distancing now required is 1 metre rather than 2 metres, and in office spaces and non-patient areas, staff are able to be sitting in their office without a mask on, providing they can maintain a metre away. It's still different in our patient areas, and we're still asking patients, visitors and staff to be wearing masks in the kind of public patient areas of the hospital, and that's consistent with the national guidance, and I think at the moment is still the right thing to do. I thought maybe we would have some more challenging conversations, because things have changed so much in the community and people would be a bit more rebellious, but at the moment, Sarah Ward and myself were chatting just a little while. Sarah Ward, our Deputy Director of Nursing, were chatting and saying actually so far it's not been too bad, and the public is still being sensible, and I think rightly considering the NHS in a slightly different light to, you know, going out to the shops and things. So just to mention that we are trying to get that message across as well as we can. There's obviously some work to do. couple of other bits around the system. There's lots still going on Joined Up Care Derbyshire about public health and trying to move on that agenda, because in the end that'll make the biggest difference to our population's health, and in the end to what the hospital's being asked to do. There's obviously always some quick wins about, if we can get people to stop smoking, that makes a difference really quite early on to admissions to hospital and health. And there's some much longer term wins. So, for example, around childhood obesity, which is obviously a real worry for the future if we don't do it. But that is something that's on the agenda, and it's something obviously that the ICS as a whole is trying to shift its focus a bit more to prevention rather than to reacting all the time, which is obviously the way we've managed things often in the NHS. Alongside that integrated care partnership, there have been some positive and constructive dialogue. I think it's still early days. The various different organisations, there's a paper a little later about the provider collaboration and so on, and alongside that, all of this is we're all kind of finding our position a bit, and sometimes we're all very good at saying, well, it would be great to work together in a collaborative rather than a competitive way, which is kind of at the heart of what we're trying to do. But sometimes then when it comes to the difficult discussions about money and who works for who and all the rest of it, it's in your own lives you'll know agreeing in principle is slightly different from enacting, isn't it? But we're at least in a position where people are positively working together. So our trust, working alongside other organisations within Joined Up Care Derbyshire, I think we're, and NHS England will kind of back us up on this. They'll say we're in a relatively good position. At least we're having the conversation, which is more than's happening in some places. What else is there? So Royal Primary Care to mention. You'll know at the end of last month, going into the beginning of this month, we have, at the request of another practice, taken on another practice. So there's a practice, so it's Royal Primary Care Brooklyn's the name of it. So it's a practice down near Hena, which asked us to get involved, and we've done that. And I understand from Joe Lacey and Peter Scriven that really that's all gone really quite smoothly at the moment. There's not been terrible upset from patients. People seem quite happy with things. So hopefully that will allow us to continue kind of working at scale in primary care and doing some of the things that when we set out on the journey, that we hope to do in the long run about improving, both that interface between the hospital and primary care, but improving public health and trying to make a difference there. So I think, I'd like to pass my thanks on to obviously the Royal Primary Care team and their work in that, because like all these things, that integration is kind of, it sounds easy, but it's a really big job. So they've done well, and I think things so far have gone quite smoothly. So there's always more to do there, but I think there's a little bit about the friends and family feed in primary care, and it talks about the patient satisfaction scores are stable at 86%. I think the context we should remember is what the position was 5 years ago, and it's definitely the case that our patient satisfaction's higher now than it was 5 years ago. That's absolutely not meaning that things are all fine, and I know some of you individually we'll have friends who've struggled sometimes to contact RPC and get appointments and get through on the telephone and things. So I'm not at all meaning that everything's perfect, but I think we have come a long way as well, and we should recognise that. And then I think that the final couple of things, you'll have seen the emergency care department coming up quickly and hugely outside the front door, all running on schedule. That's looking good from that perspective. And I'm sure our emergency teams will be delighted when we move in. We had the charity event at Chatsworth, which was a success, and I'd ask all of you to be, continuing your support of Health and Wellbeing Hub, because I think that's important for our people, and we're committed to that, and we want it to be a good place for our staff. So they feel valued and looked after, and so I'd ask for all of your kind of ongoing support with that. Car parking, probably ought to mention. We've not yet made a decision about that, but I think the national steer has changed to being one of not charging to one of charging, and the reality is if we don't do something about it, we'll be left with a 1.6 million shortfall in our costs, which in the end is related directly to the patient care we can give. But we haven't done anything yet. At the point that we're going to do something, we will obviously plan to clearly communicate all of that before something happens, and in plenty of time. And then the final thing, because I know it's everyone's favourite topic, and it's my favourite topic as well, but smoking and smoking shelters. So the groundworks for the smoking shelters are in place. The shelters themselves will be going up in the next few weeks. I haven't exactly got the date. We're obviously doing messaging around that. I've done one myself, and it is with very mixed feelings about it, but it is also in the context that we'd all kind of agreed we needed to do something differently because it's not working at the moment, and we are going to do this as a pilot, and if it doesn't work and 6 months down the line it's making no difference at all, we will be removing them or doing something different. So it's not set in stone, but that's where we're up to with that. So you may see it when you visit the site in the coming weeks. You may see there's going to be 2 shelters. There's one down by the Hartington unit, and then there's one behind near the postgraduate centre, both of them close-ish to but not directly at the entrances, to try and remove the problem from a place where it was absolutely unpleasant for staff, people smoking, unpleasant for people coming in, not showing the hospital in a good light. So that's where we are with that. So I think that's probably everything I had to say. Sorry if I've waffled on a bit. You have to excuse my excuse me as a beginner. So, and you'll have to perhaps feedback whether you want more or less in future going forwards, because then I'll try and adjust accordingly. But I'll pause for now and ask if anyone has any questions or things they wanted to comment on.
Thank you very much for that, Hal. And I have to say, I found the bullet point style of your report very digestible. So thank you for that. You've already got a couple of questions in the chat to be cracking on with. One was from Lynn: do we have any Ukrainian employees who need extra support? And then Mike Grundman, as ever, with his finger on the pulse of the fact that Hina is quite a long way away. So you might want to share with them a flavour of the deliberations at board about how far is too far. And then we'll come to Norman once you've done those.
Yeah, so as Zoe's responded, we do have a small number of Ukrainian colleagues. We have reached out to them on an individual basis, and so from my perspective as a medical director, I did it for a couple of doctors that we have, and Zoe, as she confirmed, we've done it for other areas as well. So we are trying to support them, and we've got to, I suppose, also be a bit conscious. We do have a couple of Russian employees who aren't necessarily Putin acolytes, but may feel quite difficult as well with it. So Hina isn't in our catchment area. Hina is in the joined up care Derbyshire catchment area, is probably the best way of thinking about it. And if there's so we've debated this at board, and it's probably fair to say about there's pros and cons as to how we make this work, and there are some innate difficulties, aren't there, in kind of liaising with or working with a practice whose natural referral hinterland is Derby rather than ourselves. They were keen for us to be involved as a starting point. So just for clarity, we weren't chasing them. They came to us because they thought that we could offer something to their patients. I think I probably, in the end, would be saying what we're trying to do is we're trying to offer really good care to all of our Derbyshire patients. And if we're trying to work as an ICS and all working together, then that kind of collaboration rather than competition should be at the fore. And I guess that's the spirit of saying that we got involved with Hina. There are some challenges around that. So, for example, the staff our other RPC practices are all relatively close together, so there's opportunities if there's, for example, sickness, to move staff around and to so the kind of the economies of scale in that sense work slightly better. But we had a strategy which was to expand rural primary care, because that was always our aim from the point of view of total number of patients. And in the end, the board felt it was consistent that we were doing it within Derbyshire because that was part of our integrated care system. We wouldn't be looking to take on practices outside of Derbyshire just for, and we've had a clear discussion about that because that wouldn't make sense. And I can see, Mike, you further comment, there is a danger of that, of us spreading ourselves too thinly, but there is also a potential benefit in strength in numbers. And there were some very positive things about the HENA practice, around it being a training practice, and around steady flow of new GPs coming through, which were hopefully some long-term benefit to RPC.
And also it has prompted some discussions through the auspices of the Provider Collaborative Leadership Board about whether we or Derby or the Community Trust get approaches from practices in future, how it is we between us have proper consideration of where is the best home for that practice at that particular point in time. Because at the moment, individual trusts have largely been responding to individual approaches. But I think the HENA approach has triggered an intention, at least, of us thinking about that more in the round as providers in the joined up care Derbyshire area.
I think that's very true, Helen. And of course, the DCHS, which is the community provider, also has 3 or 4 general practices under its wing in a sort of in a setup analogous to RPC. And I think there's probably a wider conversation within the whole of Derbyshire about whether, you know, for example, does it make sense for us and DCHS both to have separate primary care arms, or is there a further discussion to be had about how that would work best in the longer term?
Thanks, Hal. Norman, please.
Thank you, Hal. Yeah, very good for a first time. Very good.
Thank you.
Just out of interest, Hal, you probably know I work up at the Walton Hospital as a volunteer with the vaccination programme. And towards the end of March, we were kind of tailing off around about 100 a day. So we thought that most people who wanted the vaccine had it. The announcement then came out for 75 plus. And we've gone up to around about 600 or 700 a day again now. That's over a Friday, Saturday, Sunday. And plus we're doing children as well now from 5-year-old. My question to you really is all this being overwhelmed again by COVID? Are the most of the patients vaccinated or not?
So most of there's 2 bits to it. There's most of the patients are vaccinated now, and you know, speaking of myself, I've had 3 vaccinations and I've had COVID. So the evidence doesn't seem to be that it stops you getting COVID, but there does seem to be good evidence that it stops people getting really sick. So and these I'm now talking about national figures, but about 85-90% of the population has been vaccinated. In this latest wave of COVID, more than 50% of the people with COVID on intensive care units were unvaccinated. So rather than it being 10 or 15%, which is what you'd expect if it wasn't making a difference, the people were on the intensive care units and sick with it, much greater proportion of them weren't vaccinated. And what's actually happening to a large degree in hospital at the moment, and it varies a little bit hospital to hospital, but in rough terms, about 2/3 of our patients with COVID are in hospital, incidentally have COVID. So for the sake of argument, you've come into hospital and fallen and broken your hip, and then you're found to have COVID. So about 2/3 are without, and it varies a bit hospital to hospital, but it's that kind of figure. But that, of course, still causes an operational difficulty in around where those patients have to be in the hospital and the need for isolation and cleaning, and that's the difficulty it's causing rather than. So I think the answer is your work and the work of the other volunteer vaccinators has made a really big difference to how poorly people get at the end of it. So it's not stopping them getting it completely, but it is stopping them getting ill with it in the majority of cases. Does that sort of answer your question?
That's fine. That's wonderful. Just secondly, on your favourite subject, the smoking one, when these shelters go up, are we going to police the old areas where people used to smoke to ask them to move, or are we going to signpost it?
In practice, we're going to do a bit of both. So there's going to be a bit of signposting, but there's also going to be a bit of encouragement about. So, for example, one of the difficulties that security said they always had when someone was smoking outside of the main entrance, they could kind of politely ask them to move aside or not smoke, but they couldn't actually do anything about it. Whereas now there's going to be the opportunity to ask someone to move 30 yards down the road to the smoking shelter so that you're not upsetting other people, sort of thing. So what we're hoping is it will allow for an easier conversation, both for security, but also just for our staff members, some of whom wanted to be able to say something to a smoker, but either was intimidated about it or had tried it and got an earful for their trouble. So we're trying to make that conversation easier in the signposting. That's the hope.
Let's hope we have some success. Thank you, Al.
Thank you.
Thank you, Norman. Luke, please.
Thank you, Helen. Hal, it was just a quick question on when you mentioned we were in the top 10 in the country for A&E performance. It was just what measure are we using for that? Is it quality? Is it time waiting?
Yeah. So that particular measure is around the 4-hour wait, which is still the measure that's most widely kind of talked about. If you go on the BBC website about performance and so on, that's still the most widely. As you all know, there's a lot of other measures around, so for example, we'll talk about 12-hour breaches, and there's a difference between the national figures always being from what's called decision to admit time. So that's a person could have been waiting in ED for 8 hours before someone decided they needed to be coming into hospital, and then they might be in hospital for 10 hours before they got a bed, and actually they'd have been waiting for 18 hours in total, but that wouldn't count as a 12-hour breach. So there are lots of different metrics, and we are, alongside the national aim, to try to move to a 12-hour overall target, which is the kind of new direction of travel, which at least gives a better overall picture. We are doing that, but the 4-hour one's the one that I'm talking about. The quality one, there's obviously lots of different quality measures, which is intrinsically harder to monitor, whether that's about complaints or about mortality or it's about patient feedback. So we do monitor all of those things, but the headline figure is still the 4-hour one. It's an easy figure, isn't it, for journalists to get hold of and say this is what it is. So that's what I was referring to.
Brilliant, thank you.
Thank you very much. And more votes of thanks and appreciation for the report, Hal. So many thanks for that. And we'll leave that one there and move on.
About the 65 to 75 group morals, I don't think there is any evidence that suggests that directly.
Thank you.
Kevin's just put something in the chat as well, backing that up as well.
Yes, sorry, I missed that one. Thank you for catching that. Very good. So we'll move on to item 5, which is restoration and recovery. I know we haven't got Berenice with us, so who's handling this, Hal?
I'm picking this one up, Helen.
Oh, is Claire there to do it? I was going to say, shall I start? And then.
Good afternoon, Claire. Many thanks for joining us.
Happy for you to start, Al, if you want to start. I'm happy for you to start. If you want to, that's fine.
No, I think you'll know it in much more detail than me, Claire. I was going to give a very broad overview, but you'll be better placed to give us a more comprehensive, better report. So you crack on.
Okay, so I've just shared my screen just so that you can see the slides. I don't know everybody, but just briefly then. I just wanted to cover in terms of our waiting list position. There's a brief on health inequalities. There's an update on our planning position, currently where we're at for the end of the year. And then also an update of where we're hoping to get to in terms of 22-23 for planning. So I've tried to keep time, and so appreciate any feedback in terms of if there's any changes that we need. So I've kept the pre-COVID levels in so you can see where we're at before COVID and then obviously the post-COVID. So the things probably just to highlight are in terms of our elective care pathways, in terms of the increase of 5 weeks for new appointments, 25 weeks for follow-ups and 23 of elective surgery. Our waiting list size continues to be impacted, and obviously we've kind of been in and out of the COVID pandemic, which is impacting on our waiting list. But just some issues. So there's full validation process going on with waiting list at the moment, and in terms of our 8-week position for all pathways over 52 weeks, all of those pathways have been validated within the last 3 months. And what we're also looking at as well is how we can actually interact with patients a little bit more, and keep patients up to date with where they're at and what to expect. And as part of that, we've also used the national system, My Planned Care, to help with some of that. And happy to take any questions on that. In terms of management of referrals, we continue to use the RAS system, which is a referral to assessment system, which allows clinicians to assess the referrals as they come in, which means that they can actually target them into the right area. So you might not necessarily need to be seen in a new appointment first. We can get you in for straight to test. So it just makes it a little bit more straightforward. And in terms of the appointments that we are doing virtually within the organisation, we seem to hold that around the 28% mark. Nationally, that's at 25%. I think there are other areas where we can actually do some work, and we are looking at what we can do next year as part of our improvement plan. And so just quickly, just to say in terms of this, hopefully you'll be familiar with the format, but I've broken out the waiting times of what they were pre-COVID, post-COVID, the number of patients on the list, and then underneath you can see the top 5 specialties and the areas of where the waits are on that. So moving on, we've then got the health inequalities. So I appreciate you might not be able to see the infographics that I did for that, and I'm quite happy to share with you. So this was just to try to give some assurance around, there's a lot of focus in the plan in terms of health inequalities around deprivation and ethnicity, amongst a lot of other things as well. So just to try and give board assurance around where we were at in terms of our waiting list. So you'll see the map in the top left-hand corner, that gives the deprivation map of Derbyshire. So just kind of shows us where we're at in terms of Derbyshire and obviously where the deprived areas are. And then what I've done is taken our waiting list and broken that down into deprivation. And you'll see that they're broken down into priorities. So if you're not familiar with the priorities are P2 is our urgent and cancer patients, P3 is our routine to be seen in less than 3 months, and P4 is our routine to be seen over 3 months, sorry. And then what I've also then done is broken all of the priorities down into the average weeks of deprivation and also in ethnicity. So like I said, I'm quite happy to share that with you. I've put a bit of briefing in there as well around where our current waiting list is. So in terms of our population, so we've got 98.1% of white British and 1.9% BAME against the census population, which is 95.8 and 4.2 of BAME. And then I've just broken down in terms of the waiting list size and in terms of the risk score. The risk score. So just briefly to explain the risk score. So the way that we've categorised this as a trust is that we've taken our patients and looked at their comorbidities, and based on their comorbidities and the length of wait that they've been on their list, they receive a risk score, which does actually move as the weeks move on. So you might have somebody that's got medium comorbidities and has not been on the waiting list long, but they might be in the green, but actually as they progress further on, it will actually start to flag them amber and red in terms of where they'd be on that waiting list position. And so I've just broken that out into the scorings as well to give some assurance around our waiting list. So all in all, I guess in summary, there was nothing really of concern that we found within this in terms of our waiting list size. There obviously is still work to do, and there's still things that we need to look at, but there was nothing of real concern that we needed to highlight. And then going on in terms of the planning trajectories, so I have left the planning guidance summary in that I put in there last time, just so that you've got that for information in terms of what the aim was for planning for 21-22. And then just briefly in terms of the update, so I've included the table that you can see on the right hand side in terms of the performance of what we achieved. These are all our measures that we have to achieve in terms of our planning and what we're monitored against. And then obviously I've colour coded it, so obviously the colouring on the actuals is against the planned target, and then I've also rag rated the trajectories as to whether or not we're actually from our actuals achieving the trajectory that we set. So in terms of our overall performance for March, we were actually just 0.1% above threshold, which was really, really tight. It's probably fair to say that we did struggle towards the end of March in terms of our elective and day case capacity with some of the bed issues that we'd had in terms of having to reduce down our elective beds to hand over to non-elective. But overall, we've been in a really good position in terms of that. We've achieved good position in terms of our performance for cancer, so you can see the cancer here also. So we've achieved the 28-day faster diagnosis pathway. The one that's marked red is the number of referrals, so that just shows a high demand that's coming into the organisation. But then in terms of patients that have been diagnosed and in terms of patients that have been on the PTL over 63 days, that figure is comparable back to 1920, and work continues to reduce that further. Our outpatient position has been really good in terms of what we've achieved, so 12.1% above the 8 to 9% target, and we're actually 1.1% above our trajectory of where we expected to be. 18-week pathways obviously has been a little bit more challenging. The challenges with that are to do with our elective and our capacity within theatres and our beds, but we continue to work through that. And like I said earlier, the assurances around that are that we are obviously validating those pathways to make sure that we are fully aware of where the patients are. And then just to flag in terms of some of the impact that we've seen in March will continue into April in terms of the reduced capacity for the COVID surge that we saw and the increase in the non-elective cases. And then on the next one, we've just got a brief update in terms of our over 104 weeks. So I know that Al touched on this in his briefing, so I won't stay on this too long, but this just gives you an idea in terms of what we've got to achieve. So originally in the very first plan that we did after COVID, we were told that we needed to have a target of 0 by the end of March, but I think people realised very quickly that as COVID was coming back and we were getting more surges, that wasn't going to be achievable. So we were asked to do another trajectory in terms of achieving that by July. We have actually been challenged in terms of can we achieve that by June. So we are working towards getting to where we possibly can by the end of June. So this just gives you the March position, but actually if you look on the graph, it gives you the most recent position as to where we're at. And I think this week we're actually down at 62. So I think we've gone down again this week, but in this one it shows 65. And then what I've tried to do then in terms of the end of March position, I've broken down in terms of, you can see that 90% of them patients have got a decision to admit, but they're waiting for TCI dates. 30 of those have got TCI dates. And now that we've got the elective beds back up and running in terms of the 32 beds, we will start seeing that increase now in terms of the TCI dates for those patients. And then you'll see that there's the risk and the plans that we've got in place and what the next steps are as well in order to clear these 104 and give those assurances around that. The 22-23 then in terms of the planning update, So the ask, I'm not sure if everybody is aware, but just really briefly, down the left-hand side, the ask for next year. So our planning priorities are to deliver 10% more of our elective activity before pre-pandemic, so back again to 1920, to reduce our waits over 78 weeks. What the ask has been is that obviously the 104 goes down to 0 and the patients waiting over 52 weeks are reduced, and the ones over 78 weeks are 0 by the end of March. So quite a big ask there really in terms of what we have to achieve. Reducing our outpatient follow-up, so there's an ask of a minimum of 25% reduction in outpatients when we compare that to the activity levels in 1920, and then a possibility of going further with that. And the improved cancer performance against standards, which we have done really well this year, and we continue in that we will continue to see that going forwards. And then the increase in diagnostics in terms of increasing capacity to 120%. So they're the challenges that we were set in terms of elective care. You can see down the first column of the blue column where it says the draft plan. This was my first submission that I sent through in terms of my assumptions. So in terms of 110% of our elective activity, we were actually 17.9 below the target of where we needed to be. A lot of the assumptions around that was the bed base that we've got, the bed capacity, the fact that we couldn't increase our day case activity because of IPC guidance. I've covered the things around RTT, so I won't cover that again because our aim was that we will do, our ambition is that we will try to achieve those zeros that are expected of us. A reduction in outpatients, again, quite a bit below target in terms of it was 17.2% at draft plan, and our diagnostics was 23% below target. We've then worked with the divisions in terms of their priorities and what they need to be for next year in terms of what they will be looking to deliver as part of their improvement programmes as well. And that got us to a position of, we've got some of those are reg rated amber and some reg rated red, just because some have got real issues around funding and staffing, which I'm sure other people will be happy to cover if necessary. But just really briefly in terms of this, we've got a likely plan, and then there was the best plan in terms of what we've submitted. So our plan that we've submitted at the moment leaves us 8.1% below the target. So we've still really struggled to achieve that. But the way that we've increased that is the new guidance has come out in terms of IPC. So I've lifted the restrictions that we've got on day case activity. So there's a lot of assumptions based in terms of around what we've got to deliver. And I guess, this is our ambition. And what we've got to now do is work together in terms of how we're going to deliver it. And I've put all the performances down here. So we've seen improvement in terms of elective, there's an improvement in terms of outpatients. We're now at 20.7% in terms of the reduction, and diagnostics, we're now 15% below the target, but actually we've massively increased the MRI and CT to do with community diagnostics. And I think, and then the last page just gives you the summary in terms of, you can see very clearly in terms of the percentages of what we'd previously submitted and what we've actually finally submitted, which was in the end the best plan that we went with. Sorry, that was really quick.
Wow.
So I'll
goodness me, Claire, that was a tour de force. I'm left enormously impressed, very grateful for your and colleagues' efforts right across the trust that this is the level of performance and the ambition of our plans for the future. And if I'm honest, vaguely dizzy, because it is such a lot, isn't it, to have to cope with and contend with all at the same time. So very well done. I'm sure there'll be lots of thoughts and questions provoked by that run through you've just given us. So if I can open up, please, Margaret.
Just really to say that there was so much information there. Would it be possible for the slide to be sent out to us as a separate email so we can kind of digest it a bit more in detail, because it's amazing, and as you say, yeah, lots to do, but lots being done as well. So it would be really good to be able to have those for a little while to digest properly.
Yes, happy to do that, no problem. I thought they'd already been shared, so I do apologise, but yeah, not a problem.
Thank you.
And the other thing we might want to do after governors have had a bit of time with the whole pack is if there are any particular areas that we could helpfully have a look at as the months go by, we could bring them back in kind of bite-sized chunks. We might entrust that steer to you, Jane, if we may, because I know Quality Committee will be closely involved as this unfolds. And if you can think of appropriate and relevant and timely bite-sized chunks to bring back to governors, I'm sure that will be appreciated. Thank you. Norman. Oh, sorry, Jane, what were you going to say?
I was going to say we could possibly also put it into the next NEDCOG session, you know, the informal session where people can kind of hear firsthand and be able to question as well. That might be helpful to governors.
It would, and it would help. Everyone could have it on their knee and collectively digest it, which would probably make it easier to do if you were looking at it then subsequently on your own. So that's a great suggestion too. We will take an action in that regard. Norman, please.
Hi, Claire, thank you. Lots of information there, and as a public governor, it would help me enormously in answering a lot of questions from members of the public who ask about waiting times and how we're progressing at the hospital. And there's a hell of a lot of information there, statistics, that would help answer quite a few questions. So thank you. And I'd just like to ask Claire, has your friend opposite been on the waiting list for some time?
Yeah, it's been sat here for the past 3 years, I think. So yeah, it's been here a long time.
Yeah.
I've been put on notice that for the consent items, which includes the IPR, that governors have some questions that they'd like to raise. So I thought with the benefit of having Claire in the room, we might do them now rather than later. Not that we're asking you to account for our performance, Claire, because obviously that's for NEDs to assure governors, but your understanding of the kind of detail and the breadth which might add some interesting colour and context, if that's all right. So I'm going to go to Mike Grundman, if I may, because I know, Mike, you said there were a couple of points you wanted to raise, and then we'll come to the point Purvey's raised too.
Yeah, thank you. I first of all like to echo Hal's sentiments about the performance of the trust during COVID and pay tribute to that, because I think it's remarkable that we are still in the top 10 of ED performance, and ED performance really reflects the performance in the whole hospital, doesn't it? So I think you know, a big pat on the back for everybody concerned. So the IPR, I haven't talked about bed occupancy for a long time, and I'm not going to make a big point, but I have repeatedly asked whether we could have the bed occupancy data by division. So, you know, saying that the overall bed occupancy is 87% really hides a multitude of sins, and I'd like to know that medicine isn't operating at 120% capacity and surgery about 50%. But I just think we need to know that, and I think the trust board needs to know that. So if that could be included in the IPR, that would be very helpful. That's page 95. Just a few other points. I note that on page 109, agency spend is talked about, and obviously the biggest single section is medical locums. What level, what grade are most of these agency doctors? Are they juniors, staff grades, or consultants?
I don't know the exact breakdown, Mike, but it's a mixture of all sorts. Obviously, the most expensive people are the consultants rather than the junior doctors. It greatly varies between areas. So, for example, you know, in urology, the locum spend is all on consultants. In something like medicine, a lot of the locum spend is on junior doctors covering things. So all of that locum spend is discussed and considered at the We've got a workforce delivery group where we kind of look in detail at more of the spend. I don't know, Zoe, if you wanted to add anything, because I know you've got your hand up.
Yeah, I put my hand up. I was going to come in, Hal, and then I was going to say pretty much exactly what you've said, and exactly the way you've said it. So I was just about to put my hand down again. Thank you.
Ruth, just putting in, I apologise.
No, thank you very much.
Okay, thanks for that. Next one is page 115, the key performance indicators for maternity. And I know that there's a target for SVPs, Bs, which is normal deliveries. And in view of the Shrewsbury and Telford debacle, I wonder whether it really is appropriate to have a target. You know, in a way, it's putting pressure on staff to avoid intervention, if at all possible. Well, that happens anyway. And I just feel it should be left to clinical judgment without any without any pressure group having an influence on what's happening. Just a thought.
Krishna, did you want to come in?
Yes, absolutely right, Michael. And actually, so this is the February figures, and since then we've been Nhs App have given us not a target, but a way of looking at caesarean sections in the different categories for us to identify what that looks like. But you're absolutely right. It's not about target, and you're absolutely right. That was one of the main issues with Shrewsbury and Telford, as in chasing a target to have a normal birth, when in fact it was putting women at risk, significant risk. Exactly. So you're absolutely right. So no, you won't be a target, but it's a way of just sort of documenting trends going forward. Thank you.
And lastly, page 116, the financial report. I see that I may be wrong in my interpretation, but we are approximately 2.25 million overspent. Is that correct?
Yes, it is, Mike.
Thank you. And of which drugs seems to be the main excess cost, at 2.7 million above what was budgeted for. The next one is nursing and midwifery, which I'm not quite sure, of 650,000. And I'm not quite sure, because I would have thought that the biggest potential for overspend would be agency costs, and yet you're really running below your budgeted amount for agency. And then the next one is a 468,000 overspend of non-clinical income. This is an income as opposed to expenditure, and I wondered why there was such an enormous shortfall in non-clinical income. And lastly, medical and dental overspend of 392,000. That's perhaps easier to interpret in view of the increased locums costs. I just wondered whether you have any comments, or whether I've completely misinterpreted the figures.
You've not completely misinterpreted the figures at all, Mike. You've interpreted them quite well, in my opinion. So there's quite a big dissection going on around the overall drugs bill. As you can imagine, the way in which we've been treating patients and the changes of patient cohort we've had over the years is quite different. So there's quite a big piece of work going on there in terms of COVID-related drug costs and non-COVID-related drug costs. So that work continues. We've fared reasonably well in terms of permanent recruitment, so we haven't spent as much as we thought we would on agency, which I think is a bit of a good news story.
Yeah.
We're currently working through the overall year-end position, and we'll be reporting that into Finance and Performance Committee on Friday. So we'll give that a bit more of an outing there, if you'll allow us to.
Okay, thank you.
I think Hal's comment about you being a medic at heart could also be added by there's an accountant lurking in there somewhere too. So thank you for those, Mike. And I think that probably deals with a third of the points Pervez wanted to raise, because he too raised the issue of the variance of 2.3 million. So I think we've probably coped with that. But there are two other points on Pervez's note. One is about complaints processing, and the other is about the high mortality index. So I just wonder if between Jane and Krishna we could do those queries justice, please.
So I'll answer first if you like, Jane, since you're in Australia. Bless you. If I just talk about the complaints, we've changed the process of complaints and given more autonomy to the divisions. And we knew that it was going to take a number of months for us to get up to speed. And in fact, I've met Medicine's complaints sort of manager this morning with some feedback and sort of to see how we are. We're certainly getting more complaints through and we're envisaging getting back on track. But this is about, first and foremost, being a response that is a good response, not defensive, very open, very transparent, and picks out the learning of what those concerns are. So we're concentrating on the responses. The response times will sort of start to see over the next 2 months an absolute improvement there. It really is in the medicine division that we've seen the biggest sort of drop down, and they obviously have the majority of the complaints as well. So that's in the context. Jane, did you want to answer on anything here?
Probably just to say as well, we're not just looking at the timeliness of the responses. We're really keen also to look at the quality of response, aren't we, Krishna? So we've had quite a number of complaints that have been partially upheld, and you've probably heard us speak about that before. We've had a number of changes to senior staff who've needed support in terms of quality of complaint responses. So there's quite a big package of work that's gone into looking at complaints, but of course we know that governors are always interested in that, as we are. So we've also had have we actually had the critical friend review, Krishna? We were having a review from CCG.
From the complaints, we've spoken to the CCG because we wanted to embed the new structure within the divisions first before we get sort of the CCGs to come in. So we've got that penciled in for about 3 months' time to come in to do a sort of a critical review.
Yeah, so that's something we've done before. We've had independent review of our complaints processes before. CCG have kindly agreed to do that for us, so it's just a matter of the timing for that. So should we ask Hal to start off on HMSR? I think I can probably guess what he's going to say, but I prefer to give Hal the first bite at it, if that's possible.
No, so I'm happy to pick that up. So the HSMR, so there's different measures of mortality that we look at, of which the main two are HSMR and what's called a SHMI, so SHMI. Alongside, and excuse me if the figures are slightly wrong, but essentially it's something like 6 or 7 out of the 10 acute trusts in the Midlands. Our HSMR has gone above the expected value in the last couple of months, and it is thought to be related to COVID and the kind of comorbidity in the way that COVID is recorded in the data. And the reason that we're saying that with some confidence is because it's not just us that have gone above the HSMR. We're in the majority who've gone above the raised HSMR, and that's and actually compared to the majority, we're not, for reassurance to everyone, we're not the worst in the 10 acute trusts. We're kind of pretty much in the middle from that point of view. So we're not a kind of outlier relative to our peers. And I know Caroline and the team down there in governance are looking at the data and trying to explain it further, but it does seem to be rather a kind of related to COVID anomaly in the figures. Now, against that, and as a kind of reassurance, the SHMI is slap bang in the middle of expected. So I think our latest figures is 0.98, which is just slightly below the one expected. So we believe the HSMR thing is a little bit of the overall HSMR, this is I'm talking about, is a little bit of a statistical thing related to COVID. There are, for honesty, there are still some areas where the HSMR in particular areas is still a concern. So, for example, stroke we've talked about before, and that's still a concern, and there's still ongoing work related to that. But the overall figure, we believe, is part of it's a bit like when we had an issue about the crude mortality a little bit a while ago. People may remember that the crude mortality went up significantly during the waves of COVID, and that's because it wasn't adjusted for the extra COVID deaths. And sadly, as we know, there were extra deaths in hospital during the COVID pandemic peaks, not this latest one, but the earlier ones where there was a lot of people on ITU. So we believe it's related to that rather than to a real concern because of what's happening elsewhere at the same time. Is that your understanding as well, Jane, from reading the figures and seeing? I haven't got the paper that we had in front of me, that bit, but that's what we talked about in QAC, wasn't it?
Yeah, absolutely. That's what we talked about in QAC. That would have been my short answer. Would have been it's about case mix and the COVID cases. And I guess for assurance, what I would be saying is that where we've got areas where we are an outlier, particularly if, say, we're alerted by Dr. Foster, or when we get back to looking at getting it right first time data, then actually, you know, we are clearly identifying those areas and working on those specifics. So you've identified stroke. We've just done some work on congestive cardiac failure, haven't we, Hal, and got the bundle embedded now. So again, we seem to have turned that round. So it's about us continuing to monitor individual areas that of concern, particularly, as I say, flagged through Dr. Foster, but it is most definitely related to COVID case mix, we believe.
Pervez, has that addressed your queries, or would you like to come back?
Partly, not completely. I think the COVID is common to all the district and hospitals. It's not a unique problem for Chesterfield. So I think as far as the other point which has been picked up, that our comorbidities are high and they have not been picked up as robustly as should be the case. And at present, when we look at our cohort, it appears as if they have low expectation of death, while the reality is contrary. And part of the problem is we don't document comorbidities clearly and adequately.
Did you catch most of that, Hal, sufficiently to comment about the interplay of comorbidities and the overall picture of mortality, if I get you correctly, Pervez?
Yeah, I think I caught most of it. Pervez and I have discussed over a number of years about comorbidity and the importance of capturing that. And for what it's worth, when our coding department is kind of considered on a really, I can't remember what the body is that comes in and looks at the accuracy and the depth of our coding, but the coding department, they always, it's reported back that we have good depth of coding, meaning that we are capturing most of the comorbidities. Now, you're absolutely right, it's an ongoing challenge for them to pick out all of those comorbidities, and you'll know that we've done things in the past around pro formas, which kind of allow doctors and nurses to sort of more easily highlight some of the comorbidities that are relevant, and we continue to do that, and it's always an ongoing process, but we do try and address it. I think the specific thing about comorbidities and COVID at the moment is a slightly different issue just at the moment related to that. But I can see Claire's got her hand up, and she may want to comment a bit more about the coding because she's much closer to that than I am.
Can I?
Yes, sorry, Hal. It was just to pick up in terms of the coding team. So I have actually changed the audit, so it is a different audit company now, just to give us that reassurance, really, because I think we were using the same company and we've done that for quite some time. There was really good assurance that came back. So even using a different external provider to do the audit gave us, I think we were around somewhere between 94-96%. I think it's just worth saying as well that we do have clinical support, so we have a clinician that comes into the coding team that you know does support the coding team in terms of doing audits on the case notes that we do the coding for. So if the coders have got anywhere they specifically think these are big cases in terms of comorbidities and things, they tend to put them to one side to work with that clinician to give that reassurance.
Can I make one last point?
Please.
Trust has asked outside staff to give a report on the mortality issues in the trust. Can we have access to the report, please?
I think Purve's asking for access to the mortality report. All those papers would go to QAC, wouldn't they, Jane? And then it gets reported out of QAC to board, and there's regular reports to board, Purve's. So I think it's probably just a case of us either, you know, sending you away or signposting you to where they exist, if I understand your request correctly. So we will maybe ask John to take an action to collate some of those QAC and board insights into this whole issue, and to let Purve's have them, please. And then if there's questions that those reports aren't answering for you, Purve's, we can revisit it. It sounds like Purve's would like to make the best possible use of having a medical director as the interim chief executive to resolve his long-standing ambitions about comorbidities and the reporting of mortality. So you're on notice, Hal. Thank you for those questions. And again, Claire, a huge thank you to you for that really impressive and very comprehensive presentation. And we've got a number of actions to make sure we mind that for all the really important information it's giving us. And going back to Norman's comments earlier, perhaps after we take that detailed report Claire has shared with us through NEDCOG, we might try producing something that looks a little bit like today's chief exec report, which is a kind of narrated version of how that means we're getting on at the hospital. So we're doing well on this and less well on that, and we've further to travel on this, and we're more or less caught up on the other, in response to Norman's reminder that it's important to be able to answer questions simply that constituents might have about where exactly is the hospital up to. And it's not often easy to, you know, recall the pie chart when you're standing at the checkout in Tesco. But if we give you a few kind of bullet points about where things are at on the back of that session, I'm sure that will help in the communication that governors have such an important role in doing for and on behalf of the Trust. So we will endeavour to make that a product of the discussion we will have at the next NEDCOG. So, very good. I think we're caught up with the questions and there's no more hands, in which case, thank you again, Claire. And we will go on to item 6, which is the digital agenda update. John, please.
Thank you very much, Helen. For those of you that don't know me, my name is John Court. I'm the Chief Digital Officer here at Chesterfield, and I'm responsible for doing the digitalisation within the Trust, and also as a system, as an integrated care system, working with other colleagues from other providers. There's an awful lot on the so-called digital agenda, but at the bequest of governors, we've come to give some exciting new developments to the patient portal, not just inside the realms of our hospital, but also new, fresh news for colleagues on the call about the national mandate for the use of patient portals, which I believe will make an enormous difference to the patient experience and a very important new way of communicating bi-directionally with the Trust for the patients. To that end, I've taken the liberty of inviting Amy Rowland onto the call, who's the expert project manager who works with me on this project. We've recently got hold of a significant amount of money via competitive national funding, and we have plans that we hope that will really make a significant difference. So regarding that, John, are you driving the slides? And then Amy doing the talking, I think.
I am, John.
Okay, sorry, I apologise. If we could have the slides up, and I'll open the floor up to Amy. So Amy, thank you very much for coming along to help support me.
Thank you, John. Can everybody see that now?
Yes, thank you.
Yeah, that's perfect. Thank you very much. Good afternoon, everybody. My name.
Could you put it on full screen so we can read it better?
Yeah, sorry, it is a little bit small. If you could get it on presentation mode, it might be a little bit clearer. There we go. That's perfect.
Thank you.
Is that better? Perfect. So good afternoon, everyone. My name's Amy Rowland, and I'm one of the project leads here at Chesterfield Royal. I've come along today to talk to you about Patient Hub, which is one of the projects that I'm working on. Next slide, please. I'm going to touch on all of the modules that we will be adopting as a trust of Patient Hub. So we've got some modules that we're currently live with, and then we have some modules in the pipeline in line with the national plan. So the first module I'm going to touch on is the appointments module. So this is a secure online patient portal that provides one place to access all appointment information, either by your smartphone, tablet or computer. It also doubles up as an appointment reminder service by text or email, whichever your preferred choice. We implemented this back in June 2020. Sorry, next slide, please. And the idea behind this was to improve patient experience as well as utilisation rates for significant trust expenditure on using postal services. So once we're fully live with Patient Hub, it's expected to cut our postage bills in half. We've also got the environmental savings with a reduction of printed letters, and also improved patient engagement by digital communications. So patients will have 24/7 access to their appointment information. Next slide, please. So making a difference. In the last 4 months alone, Patient Hub has sent out 40,000 reminders to our patients. So this will help towards our DNA rates at the Trust, which stands for Did Not Attend. And 41,000 new appointment notifications have been sent out as well. We're now live with 51 Medway specialties at the Trust. So Medway is our main patient administration system. And for those 51 specialties that we're live with, we've got a 66% average patient uptake. Thank you. Next slide. The next module that I'm going to touch on is I've Arrived. So I've Arrived was introduced in response to COVID-19. What the module is aimed at is streamlining the flow of patients coming into the Trust for essential face-to-face appointments. So how it works, it acts as a virtual queuing system. So when you arrive for your appointment on site, you'll be advised by a text to let us know you've arrived. And then when the clinician is ready to let you in for your appointment, we'll invite you into the clinic. So this will remove any crowded, busy waiting areas, making the patients feel more at ease when entering the hospital during uncertain times. We're also planning on expanding this further in the Trust and utilising the main seats in the front entrance of the hospital to manage the flow of patients coming in for all the other clinics across the Trust as well. Thank you. Next slide. Patient surveys is one of the newer modules. This is one that's currently in development at the minute. I've provided an example on screen there of a text message for a pre-assessment survey. So how we're planning on using this tool is to act as a diagnostic tool towards patient care. So this will help for patients to manage their appointments and also to provide better outcomes for appointments. So the patient will be sent the survey, complete it, and then the results of the survey will then determine the level of patient care required. So whether this be a face-to-face, a video or a telephone, it will also mean more meaningful consultations for the patients as well. Next slide, please. Okay, so I've just touched on the top 3 modules there, which is the appointments, patient surveys, and I've arrived. And at the bottom there, we've got PIFU, which stands for Patient Initiated Follow-up, Nhs App, and Results. So these 3 are fairly new, and we are looking at developing these in the near future in line with the national plan. I can't talk too much in depth on these today because they are very early days. But the PIFU module is based on, it's similar to the surveys module, but it's how we can help manage patients that are currently on a waiting list and allow patients to feel more in control. So we'll utilise the survey functionality, and we'll also look at automating the booking process as well. We have got a target as a trust to reach by end of March 2023 for 5% of patients to be on a PIFU pathway. So hopefully this software will help us reach that as well. We've got the results module, which we will be looking into in the future for patients to receive their investigation results via digital comms. We are aware that this does require a lot of resilient processes to be in place to ensure that patients receive these securely and safely. How we're going to approach this, we've received some guidance this week that all these results will be going via the Nhs App, which brings me into the last topic there, which is integration with the Nhs App. So the end goal for all of the patient portals, including Patient Hub, is to link in with the Nhs App, which will provide a one solution suits all for patients. So you've only got one app to access all your healthcare information, whether it be your GP appointments or your healthcare at the hospital. And that is it from me. Next slide, please. Thank you all for listening. Has anybody got any questions?
Thanks very much, Amy. I think what's really important from an end user experience, because not all of our patients in the Royal go just to the Royal, is that the strategic change of direction over the last 2 weeks is that the Nhs App will become the single point of truth for all of your primary care, your GP, your allied healthcare care, and your secondary care. And products such as Netcall and others that are in the system and others are used in Derby will still be used by those providers, but as a patient, your experience will be one single point of truth and one app. And I think this is one of the most important bits of change of digital that we've actually seen come out of NHS Digital and NHSX in a considerable period of time. We have obviously partnered with Netcall, and Netcall are right at the top of the list for this functionality to become real. So the trust is an opportunity to have the national funding to deliver this, and we're already well on the way to delivering it. And that's what I thought would be most helpful for the governing body to hear today. Thank you.
Thank you. Sorry, Norman, have you got a question for me?
Yes, Amy, thank you. I've recently had some messages because I'm going through appointments at the hospital at the moment. And I had an appointment that I didn't know about until I was messaged by the hub.
Oh, right.
That was the only way I find out. Now, is there any way of me accessing the hub other than you sending out a message?
So if you've been sent a message previously, you'll automatically have access to the hub. So yeah, you should be able to access.
So how do I access that then? How do patients access it?
Via the URL, the patient hub URL, which you'll receive in your text message. So if your appointment letter has been placed onto the portal, you'll be provided the URL to access the information in your text message. Does that answer your question?
Yeah, I'll have to have a look at that, because the other thing is once the appointment's gone, the letters go, they disappear. You can't go into your history. I don't know if that will be the case.
You should be able to view your letters on your historical letters on the platform as well.
I couldn't do that. It said that appointment's gone, and that's all it said to me.
Okay, I'll have a look into that for you. Is it all right if I link back in with you?
Oh, yes, yes, please.
Yeah. Okay, no problem, will do.
Thank you very much, Amy, and then we'll know whether this is specific to Norman or more widely, so that'd be good too. Nick, please.
Yeah, good afternoon, Amy. Just a couple of points. The I've arrived system, will that be replacing human contact at the reception area and the touchscreen system for booking in?
It won't be replacing the human contact, no. And I don't believe, I think if Claire Carson's on the line, she'll be able to add input as well, but I don't think it will be replacing the check-in systems unless, Claire, I don't know if we've got plans to use them to utilise it as well.
So yeah, I'm not proposing that will replace the check-in system. So the check-in system will still be there. The only difference will be in terms of the reception area is potentially we'll start to move more back to the suite area. So there'll be receptionists based in the outpatient areas rather than perhaps in the main area. And in the main area, it will be more about a guide that will point people into in the right direction.
Yeah.
Right. So the reception area will be more of a holding area for those that have said that I've arrived through the app, yeah?
Correct.
Right. Secondly, I think the results part can't come quick enough. I think there's nothing more frustrating than having an MRI scan or even blood tests, and then you're left in limbo, especially if you've not got a follow-up appointment for 3 months. You know, you're left for 3 months wondering what's happening, wondering what the results were. Sheffield have had patient view for several years now, which you can have a blood test and then the following morning you can log on, look at the results, and there is a guide test by test, say, for blood results, saying what the test is about, what the normal range is. I just wonder whether for things like blood tests, whether there's a quick fix on using a system such as Patient View, which also enables you to look at letters and reports as well. I just wonder whether we're reinventing the wheel or whether it's already been invented in Sheffield.
So from my understanding from what you've just said, I believe our Patient Hub is similar to what Sheffield are using, which is called Patient View. So yeah, we're hoping to get to that stage with Hub where we can get the results sent out similar to blood tests. But at this moment in time, we've not decided the approach as to how we're going to do that just yet. But it is in the pipeline to get to that point, definitely. John,
are we in contact with Sheffield to try and learn from their experiences? They've been running this now for 3 or 4 years, so they've actually been through it now. I just wonder whether we could liaise with them and try and pinch some of their ideas or learn from their mistakes or whatever.
Sorry, yeah, can I just confirm whether that's Sheffield Children's or Sheffield Teaching, please?
No, it's actually we get it through my daughter, who's a transplant patient and has to go to the Northern General.
Okay.
And she's an adult. She's a special needs adult, but right. She goes to the renal clinic at the Northern General.
Yeah, no, definitely. As part of my implementation phase, I will link in with surrounding trust to learn from their experiences. So definitely, thank you for that. I'll take that on board and speak with Sheffield.
John, would you like to come in?
Yes, just to offer some more information to you, Nick. Yes, the renal patients and certain other long-term conditions in Sheffield do have that facility. We would want to have it all-encompassing, and there's quite a lot of subtlety around results being reviewed, and maybe not ongoing anemia or UTNEs, but ongoing results such as MRIs or complex investigations, which may actually have really quite significant outcomes to the patients. And we have to be really careful, and we're working through it, to be sure that any very significant life-changing diagnosis is not read on a mobile phone. So that's not the way we'd like to deliver healthcare. It's obviously not right. It should be patient-centred with the clinician. Yeah.
So I mean, I understand that point, John. But is there not a case for maybe on critical examinations where there may be bad news to deliver, there being a time lag so that it gives the consultant time to actually get to the patient before they see it on the system, so to speak.
So that's exactly what we're working
it's a slightly different thing.
We're working through all of it because we really need to be sure that we're safe. Having said that, I have spoken to Sheffield, I have spoken to the head of IT and their chief clinical information officer. So we have an understanding of the processes that we've got, and we will be reflecting that back to Netcall, who are our provider. So I agree with you, it needs to happen. It will. I can't give you an accurate timeline today. Once we've got one, I'll be sure to let you know.
It sounds like there's plenty of appetite, John, for you and Amy to come back to us as your plans firm up. So thank you for those helpful lines of inquiry. Ruth.
My queries on the same lines as Norman actually was, can a person opt out of Patient Hub? I had a friend who had an orthopaedic appointment, got the appointment through the hub and got the reminder. And then got a second reminder within 48 hours before the appointment. The letter on the hub says, please be available an hour before the appointment and an hour after the appointment, which is fair enough. But this friend, basically had not been rung, and it was an hour and a half after the appointment time. So she went back to the mobile phone to see if there was a number that she could ring or text, and it had all that can't think the word. All those letters had disappeared, which is what Norman had said.
All right.
So she actually landed up by having to ring the hospital switch number and asked to be put through to a new patient department to see if they'd got her online, and said yes, you are still in line, the consultant is running over. So she did get the appointment. So bearing in mind now that this friend has got early dementia, and the consultant has said we will speak to you again in a year's time, the family are worried if they, the mother doesn't see it on the phone and so ignores an appointment. So can a patient actually opt out and stick with letters?
Yes. So thank you.
How do they opt out?
Thank you for that, Ruth. So yes, patients can opt out in answer to your question, and to opt out they'd contact the central booking team who'll be able to opt them out, or when they come into the hospital just mention it and then we can get one of the staff members to opt them out.
Okay, and as Norman says, that you said you'd look into it, because those three these three texts have totally disappeared. So there's no way that they can follow up.
Okay, yeah, definitely. I will look into that and I'll feed back, because you should be able to view your letters.
Yeah, thank you.
No problem, thank you.
Now we've got Jeremy, John and Mike in an orderly queue. So could I encourage you to be jaunty in the pace at which you ask your questions, please? Then I'm going to give everyone a 3-minute break, and then we'll have just about half an hour to do justice to the rest of the agenda. So that's the plan for the rest of the afternoon. Jeremy next, please.
Okay, thank you very much, Amy and John. This is all to be applauded, but can you assure me and us that people who aren't digitally connected are not going to be disadvantaged in any way by these developments?
Absolutely. I can completely assure that there's no compunction to be part of Patient Hub. There is no coercement, and if you're not in the hub, all standard processes still apply.
Thank you very much. John Kay, please.
Thank you. I access everything through the NHS app, particularly from my doctor's records and things like that. It works very well, and there's also consent forms that you have to fill out to make sure that everything works properly. Mm-hmm. Is your hub going to be on that? And if so, when is it going to happen?
Yes. Shall I get this one, John? So the plans are that we will link in with the NHS app. It is in the pipeline. We're working closely with Netcall to develop that, but we haven't got a timeline at the minute to provide, but hopefully we can provide that in the near future for you.
And my follow-up question was related to the integrated care system and the ability of you to all share data between each other. That's something that I think is going to be very important when you get further down this agenda. Is there any plans for integration in that respect?
Yes, John, there is a Derbyshire shared care record that went live 6 weeks ago, sharing just patient data for clinical care. It's not a data scrape for research purposes or such like, to put everyone's minds at rest as what happened 2 Augusts ago with the previous Secretary of State for Health. The shared care record at the moment is in the proof of concept, so it holds the data that we could share crudely prior, but this can now hit every screen of every healthcare worker in the joined up care Derbyshire community, and we'll soon have social care and community on board as well. So that's a 10-year rolling programme, as I say, launched approximately 6 weeks ago. So at 3 o'clock in the morning in an emergency room, a clinician can see the GP record, which is the example that I normally give. So we're on the way. We don't hold all the data sets in there. It's incremental. We know we have all of the letters for Derby and Chesterfield for the last 5 years in that record as well already. So it's becoming a powerful tool very quickly.
Thank you.
And last word on this item to Mike Grundman.
Yeah, if I understand you correctly, the reception function is going to be devolved now to departments, in fact, as it was 10 or 15 years ago. I mean, many clinicians, and I was a clinician at the time, thought that it was a retrograde step to centralise all reception function to a big desk in the entrance lobby. But the great advantage of having a receptionist in each department was that there was a great personal touch, and most of the receptionists were based in that particular clinical area and got to know patients and, you know, could perform a much higher level of function than they do at the moment. So I'm delighted that it's going to be scrapped.
I knew that was going to please you, Mike. As soon as Amy said it, for reasons I understand absolutely. So on that note, let us thank Amy and John. I mean, it's just fabulous to have picked this agenda up in the way we have, with such determination, but mainly with such vision and ambition. And I, for one, couldn't be more pleased about our direction of travel on all of this. And I'm enormously grateful to John for his leadership and for having people of Amy's calibre and quality really advancing the agenda. And thank you both for telling us about it today. So you've now got 5 minutes to powder your noses, top up your glasses, do whatever it is you'd like to do, but please may you be back at your desk by 5 past, and we will carry on. Welcome back. Many thanks. So we've got some really interesting items left on the agenda for this afternoon, including a query from Mike about the weather, Jane, that you might respond to in the chat. But the next item on the agenda is Derbyshire Healthcare and the Hartington unit. And we've had questions from governors before about the Hartington unit and trying to understand a bit more about it, because obviously it's on the site, but we're hosts to Derbyshire Healthcare, who run the facility. And we're joined this afternoon by Jeff Neild, and I'm delighted you can join us, Jeff. And you're a very welcome guest, and the floor is yours.
Thank you, Chair. Good afternoon, everybody. I know we're short on time, so I'll very quickly whip through. I've got a couple of slides, but nothing. They're mainly pictures more than anything, and then I'll quite happily answer any questions that anybody's got at the end of that. So if you just give me 1 second. Can you all see that? Yep, I can only see Helen. Is that? Are you able to see that? Yeah, brilliant. Okay, let's just try and put this onto.
Might help if you could put it on slide view, Jeff, because some people find it a bit easier to read.
Yeah, I'm trying to do that, but my laptop have done an update as usual today. There we are. There we go. Okay, so we're calling our programme Making Room for Dignity. This is an outcome of a staff engagement where to name the programme, because it was previously the Dawn's Eradication and PICU programme. This really isn't playing, is it? Sorry, my laptop's just on an absolute go slope. Right. So the key aims of the programme are to eradicate the use of dormitories across the whole of Derbyshire in mental health inpatient provision, and the use of inappropriate out of area PICU for both male and female. And a key part of the programme is that we're using national evidence on single sex, sexual safety, etc.
So what need to explain that PICU is psychiatric intensive care unit.
Sorry, yes, I should remember from my days of working in acute, we use a different language, don't we? Sorry about that. So what this means for the north of the county, which is what I presume the people on this call are more interested in, although I'm sure they're interested in all of it, is the delivery of a newly built 54-bedded adult acute inpatient unit on the site opposite the current Hartington unit. All of this in a single room en suite. This is an increase of a net of 2 beds for Northern Derbyshire. We've had a look at our demand profile and moved 2 of the beds to the north. We have the ability within there. We've got 3 18-bedded wards, but we can flex for gender requirements. So we've got primarily 1 male, 1 female, 1 primarily female, but we can move that to a configuration where we've got 7 of one gender, 7 another, and 4 of either of the other genders, or we could host non-binary or trans-binary patients without any single-sex issues. So very progressive configuration of the wards there. We're only having that configuration in the north because that satisfies the whole of our need for Derbyshire. We're also at the same time going to move our older adult patients from the Plesley ward onto Blue Ward at Walton Hospital, and we're currently working with Derbyshire Community Health to look at how we're going to reconfigure that ward to suit those needs. And that's going to be a 12-bedded configuration. And again, with single sex in mind, we can flex that to 6-6, 8-4 or 3-9 configuration, depending on demand. Obviously, with the demographic of older patients, we tend to get more female patients, but that's not always the case. So this is the programme that we're working to for the new build. So we're looking to start construction in September, 5th of September to be exact. We expect to be completing practical completion by the end of March. So that means the building will be recognisable as a building, but there may be some bits of snagging and painting to do. We're then looking to for the unit to be commissioned by June 2024. Which is 52 patients transferring from the Hartington unit and 2 patients transferring from the Radbourne unit. And as you can see there, that because of the different configuration, that doesn't create a demand for extra staff. So there's going to be an increase in employment in the north, as there are all the way through the programme. So quite a significant impact there. In terms of what we're building and where, The where is going to be on this patch of land here, which I hope you can see. So they've got the Hartington unit here. You've got the car park opposite, and then the laundry is just to the top right-hand corner of the diagram there. Hopefully, if I've been clever enough. Yeah. So what we're building is this unit, and it will sit there in terms of where it will sit on the site. So you can just see hopefully you can just see at the top end of the site there, you can see your health and wellbeing centre there, and the mugger pitch that you're going to be building, the multi-purpose games pitch you're going to be building. So that fits very snugly in that patch of land there. And we're going to be sharing a strip of land in between the two. So this rectangle that's shown on this section here won't actually be there. That's an energy centre we were originally going to build, but we've worked with Chris Tan and the team, and we're actually going to take an energy feed from over the other side of the site, the other side of the road, sorry. We're going to put in a packaged substation in there next to one that you're putting in for the health and wellbeing centre. So they'll be in tandem, and we'll feed across the energy across the road, turning right for our centre and left for yours. So we're working very much with Chris and the team at CRH. Here's what it's going to look like. These are some of the visuals that we've had created by our architects. So you can see there'll be a nice main entrance to the one in the bottom bottom left-hand corner is what the main entrance will look like. So that's the view as you walk. Hopefully that guy won't be walking there because he'll be on the link road going around there. But that's what the unit will look like. And you can see the various elevations. And the one on the top right-hand side is the inner courtyard, just to show you that that look and feel is permeating all the way through the designs all the way through. So that we've gone for a sort of modern campus look. We want it to look contemporary, but obviously we don't want anything that looks out of place with existing buildings on the site. So we've worked with the planners, and we're working with Chris and the team in the States to make sure that what we build blends and enhances the area, but doesn't stand out and look out of place. The bricks match all of both the sort of Victorian and newer bricks that you've got around that end of the site. So there's a lot of work gone into the look and feel of the design, but that just gives you a view of what the visuals will look like. In terms of older adults, we've got confirmed use of the blue ward at Walton. We've done full public consultation on this because we're taking patients off site. We've had no objections raised to that consultation. The building that we're moving into has got some latent floor defects from when it was built, so that there's an issue with the substructure underneath the floor coverings. Derbyshire Community Health have got a programme in place to resolve that. They need to move green ward over to the blue ward, the side that we're taking, to get that side resolved first. We're going to get the floor sorted out, and then we're going to move into the other side. No firm date set yet, but I'm working with the team over at Derbyshire Community Health to get agreement on the start date for that programme, and we're looking to complete this financial year on that part of the programme. And we've got a general email address there for inquiries should anybody wish to send us any questions after this session. So I'll take that down, and I can see it.
That's more than enough to lubricate discussion, Jeff, and I'm sure there'll be a number of questions and a really helpful update on what's planned. We had a question from our lead governor earlier about associated implications for car parking. I don't know if you want to raise that now, Margaret.
Yes, I will do. And your visuals have actually clarified it a bit better. I had seen some plans, but your visuals have cleared it up for me. But my question really is, going back sort of pre-COVID times, we were talking at one point, because of our car parking difficulties on site, about extending car park 8 as a possibility to make some more space. Now, Hartington, the new Hartington build is going to go over on that side, and the Wellbeing hub, they may not actually, from what I've seen today, actually impinge on car park 8, but they certainly may prevent any thoughts of expanding car park 8. So have we had any thoughts or conversations about car parking generally on the site?
I think that's more a question.
It's a specialist topic, Lee, isn't it? Do you want to help Jeff on this, because it goes beyond just the Hartington bill, doesn't it?
Yeah.
Yes, I can field a car parking question for old time's sake. It'd be rude not to, I guess. So I think the critical additional challenge potentially for site access will come with the what do we use the old Hartington unit for, which isn't resolved yet. So if there's a huge footfall of folk into there, it could provide an additional challenge, just as a sort of point of fact in terms of where we're at with parking today before we've switched back on any form of charging, which might act as a bit of a disincentive for people to arrive on site by car. We're not doing so bad. So if you look at the sort of co-op car park the other side of the road, there are a number of staff parking in there, but it's not quite full yet. But there is a downstream risk, absolutely. But I think the risk is probably more prevalent at the point at which we decide what are we going to use the old Hartington unit for, which isn't resolved. Is the answer I'd perhaps give. It's not a complete answer, but there's no take from the build of itself to take away any car parking spaces. And the point at which there'll be additional site demands will probably arrive when we've worked out what we might use the old Hartington unit for.
Yeah, and we're also reducing the number of beds on site by 12, which will naturally reduce the demand for car parking in that area as well.
Yeah, I mean, I absolutely support what you're doing. I'm sure it'll be a huge benefit to both the patients, you know, the users of the service and the staff, because the existing unit is definitely well out of date, isn't it? So, you know, I think it's great that, yeah, that you are doing this, but it does have some knock-on implications, and I know our constituents will be asking the same sort of questions about the car parking, so that's why I raised it. So, but thanks for that.
I have a really probably kind of slightly daft question, Jeff, so bear with me. We're moving 12 beds up to Walton, yeah? But in total, we're increasing the number of inpatient beds by 2 in North Derbyshire.
Yeah.
And one of the objectives of this project is to have less out-of-area PICU patients. So is 2 extra beds really the answer, or would it have been a fairly small marginal cost to have a few extra beds over the extra 2?
They're 2 separate questions. I'll answer the second one first. In terms of looking at the demand for inpatient beds, we are building the building so they could potentially have a 4th ward added at a later date, although that's unlikely. So that we're building there's 18 beds over 3 wards. 2 of them are stacked up on top of each other, so we could build over the single-storey ward if needs be. The PICU requirement is actually being met through the building of a PICU at Kingsway at Derby. So that's a separate building. So we're building 2 54-bed acute units, 1 in Derby, 1 in Chesterfield, and then we're also building a 14-bedded male PICU in Derby as well, which will take care of the needs of the county.
I'm with you. That's really helpful just to know what our bit is relative to the totality. That sounds very encouraging in terms of provisions for the county. So that's great. Listen, we can't thank you enough for coming, Jeff. It's lovely to hear it straight from the horse's mouth, so to speak, and to see all your lovely, photographs of what it's going to be like. So thank you very much.
Thank you for the invitation. Thank you
all. We're going to go on now without further ado to item 8, which is the Shadow Provider Collaborative Leadership Board update. You've got a very extensive set of papers in your pack that probably tells you much more than you'd like to know about how all this is going to work. So we're going to ask Hal to continue in his great start of simplicity and to summarise what this is all about, probably in words of no more than 1 paragraph, if you can manage it, Hal.
Yeah, I shall do my best. Thank you, Helen. So you hopefully all had a chance to read the paper. Essentially, what this is about is it's part of our new integrated care system and new ways of cooperative rather than competitive working. So in simple terms, Derby Hospital and ourselves used to be competing for custom, because we used to have a system called payment by results, where if we did a lot of orthopaedic operations, we got funded for them, and that would be helpful to our finances, but not necessarily always helpful to the overall finances of the NHS. And one of the things behind the ICS as a concept is that we're kind of removing the commissioner-provider split, we're removing the competition between providers with a view to a more cooperative approach, and linked to that is this paper, which is about a specific part of the integrated care system, which is the providers within Derbyshire working together as a collaborative leadership board. And in the first place, this is in a shadow form, and that's to do with the legislation for an ICS doesn't really come online until July later in the year. So this is a kind of forerunner to what we hope will be the case going forwards. There's 6 providers, which just for, and I'll now forget one of them, but for clarity, essentially is ourselves, is Derby Hospital, is DCHS, is the Derbyshire Healthcare Mental Health Foundation, is DHU, and then I'm going to say it is, what have I missed?
Primary care. It's primary care.
Yeah. So they're the various providers, and the whole concept behind this is to, by getting the providers to work together, that you have an opportunity to, as it says, reduce unwanted variation and inequality in health outcomes, and that's linked to the work of the Getting It Right First Time project, so GIRFT as an abbreviation, and that's to do with trying to get high quality care at the best value, if you'd like, for the country as a whole. It's meant to hopefully improve resilience. So, for example, if Derby Hospital was struggling with its orthopaedic workload and we had some capacity, we could come in and support that, and obviously and vice versa. And it's also to ensure that where appropriate, some of the subspecialty work happens in a sustainable way. So it may, for example, you know, we don't do renal transplant surgery. That's not appropriate for every hospital in the country to do. So there's sensible rationalisation of different specialties. So that's the background to it all. What we've been trying to do so far with the Shadow Board is not to kind of govern this to death. And so we have taken a bit of a, we're on a journey, but we're going to start somewhere. And if we don't start somewhere, we'll never get anywhere if we spend all our time working about how it all fits in together. So it absolutely isn't a kind of in a final form, but we are on a journey and hopefully trying to make some progress. So we're trying to do it and develop it as we go along, which I think is the right process. So really, the governors are asked to kind of note what's happened so far, and to be aware of that, and hopefully to support the adoption of the partnership agreement, which has been kind of agreed by board. So the partnership agreement essentially is us all saying we're going to work together, but it's not quite a formal, because we're all independent statutory bodies at the moment, we haven't yet got to the point where we're all completely sharing that decision-making process. So we're working in a cooperative way rather than a kind of
delegated way. So there's no request for any delegations.
Yeah. And therefore, that's the position we're at the moment. There's obviously going to have to be careful consideration about how that impacts on us as an independent body if we decide that we're going to be delegating some of that decision-making responsibility to the provider board as opposed to us as an independent foundation trust. So I'll pause there.
That's really helpful, very clear. And of course, I suppose there's no request for delegations now, but there's an indication that it's not beyond the bounds of possibility that in the fullness of time there might well be. So it's just about keeping governors in the loop.
Exactly, yes.
Yeah, and the board have been happy to approve this, but I suppose we wanted your blessing that you thought we were doing the right thing. But I think, to be perfectly frank with you, at this stage it was all pledging our best intentions to work together as well as we can in the best interest of the patients of Derbyshire. It would be very hard to object, wouldn't it? But that's without prejudice to wanting to probably have much more sight if and when we get to the point of any delegations, but we're not there yet. On that basis, are colleagues happy to note the report?
I think Margaret's got a question, perhaps, or a comment.
Thank you, Margaret. Margaret, all yours.
Just a kind of vague concern. I know this is the way we want to work together. Reading the papers, my only concern is is this at some point going to end up causing delays to implementing things that we want to do? Are we going to end up in a situation where, you know, we decide in the Royal that we want to make a service change or a development to a service, and we've got to think, oh, well, hang on a minute, I've got to take that to the provider collaborative and get their, you know, agreement, as you know, and has everybody then got to use the same pathway across the system? That was my only background concern as this develops, and I need to, you know, just think we need to think about it as it's developing rather than, you know, when it's happened.
As the chair of this group up until last month, Margaret, my response to that would be, I think the equal and opposite risk that we're not yet doing enough in concert is probably the more worrying one. So we've had some examples recently, for instance, about trying to get joint appointments on digital or joint appointments on FDs and what have you. And despite the fact that we're all absolutely agreed that that might be the right thing to do in the future, it's not the right time now. So I think the risk that is materialising at the moment is probably one of caution. That's actually getting us doing more of our own things rather than taking the risk of collaborating. So I absolutely acknowledge the risk you point out, and it may materialise, but unfortunately we're some way off it, and consequently there are equal and opposite risks. Yeah. Anyway, work in progress, I think, as Hal has indicated, and I'm sure again you'll keep us briefed as matters move on. And I'm particularly excited to see the list of clinical priorities emerge, because there's only so much talking you can do about working together until you decide what it is you want to work together on. So I think when that list gets firmed up, that will be, you know, a really encouraging step in the right direction. So thank you very much for that. And that brings us on to the next section of the paper and the agenda rather, and paper 9, which is just to reflect on the joint meeting of NEDs and governors. You're on, Jane.
So I'll be brief, Helen. We had 2 topics at the last meeting. One was primary care, so it was about Royal Primary Care Brooklyn, and the second one was about maternity. Both topics really well received and very well supported by our exec colleagues, so quite a positive meeting. We also did some comments and queries from governors, as we always do. The main problem, and it was a problem really, was about communication. So we've given some feedback to Carly, and that's a piece of work that I'll be picking up when I come back, just to be really clear about what it is that governors expect to receive and the timeliness of receiving that information. There have been a few problems around that. So Carly's very receptive to thinking about that. And then the second thing I'd just like to say really was, please, if there are any other topics that people would like for discussion. So we've talked about RTT today, or restoration and recovery. And also I know that Margaret would like to start socialising the role of the lead governor in preparation for the end of her tenure. So I think what we'd like to do is start a conversation with governors to understand the kind of the breadth of that role, rather than perhaps what some of the governors see, which is just Margaret's performance at Council of Governors. So there's so much more to that role, and I think it's important that we begin to find some interested parties to take over that role in future. So that's all I wanted to say this afternoon.
Super, thanks, Jane. Is there anything you want to add, Margaret?
No, except that Nicola and I have had another meeting with Carly about the communications issue, and you know, I think we're maybe getting a better understanding between us as to what sort of things governors need to hear about and the timeliness of that. So still a work in progress, but you know, I think we have made some progress on that one.
That's great. Thank you very much. Are colleagues content to note that report? Yeah, thank you very much. The charity update, please, Atul.
Thank you, Helen, and good afternoon, everyone. I've just got a few slides, if I can just get them on screen for you. Here we go. Everyone see that?
Yes.
Okay, thank you. Just 3 quick things I'd like to cover. what the position was for the charity last financial year, what the current situation is, and a few words about the Health and Wellbeing Hub project. So pretty healthy position in terms of last year. These are not audited figures, but just sort of management information. We've increased our funds overall, and the incoming funds, we had a large contribution from DSFS, for which we're very grateful, which has helped to get that figure up. But we were also able to continue our work of giving out grants for useful projects. And to give you some idea of that aspect of our activity, we funded 48 projects over that year. Most were quite small, less than 1,000, and many were just a few £100s. And just to give you an example, rather than a list of all the 48, there are 4 examples that give you the breadth of the kind of activity that we've been funding. For the current year, we're prioritising getting volunteers up and running. The volunteer programme is getting underway now with an induction set up by Ken for those who've agreed to get involved. We're also working on broadening partnerships within the community. So Chesterfield Football Club and Chesterfield Cricket Club, with them we're agreeing a package of activities or measures or resources that they can actually help us with and that we can use as part of fundraising activities going forward. Many of you will recall the charity hub space that's in the main reception. That's getting more used now. Ken's basing himself there when he's on site, as it were, but it's also being used by some of our community partners. So the Derbyshire Constabulary, for example, did a session there in terms of their input. And staff are also using that space for other fundraising projects themselves. Staffing resources, I think that's something that the committee will be considering next week, because we have quite a lot on our plate to do with existing work, this kind of work, but also the Health and Wellbeing project as well. So I'll move on to that. As Hal said in his report, thank you for that, Hal, the event itself was very successful. It's the first time we've ever done it, as you know. There were inevitable teething problems along the way, and it did consume a lot of time and effort getting it ready, but we're very, very grateful for all the people and colleagues that have helped to make that a success. The next stage obviously is to follow that up in terms of the contact. It's very useful to get a wider cross-section of the community interacting with the hospital through that event. We now need to see, if I can put it quite bluntly, the colour of their money, and a number of follow-up actions are agreed and will be happening over the next few months. As far as the building itself is concerned, correct me if I'm wrong, Lee, but the contracts have been signed with Stepnell. Lee and I met the contractors a month or so back, very impressed with their kind of attitude and approach to the project and their willingness to get involved in sort of the wider aspects of the project, more than just a build project for them, as it were. The first part of the contract with them is to get the planning, and that's anticipated around June, so we're waiting for that. And then the project will complete, the build will complete around February. So pretty quick once it gets going. And as you know, around that is all fundraising for the balance. We've got about $1 million, slightly over $1 million so far, and about a similar amount to raise. So there is a multi-strand fundraising strategy that includes community fundraising, corporates, grant-making trusts, high net worth individuals, businesses and others as part of that. As I said, my slight concern is that there's a lot of work involved with all of that. We don't want to curtail the work we're already doing as a charity in terms of supporting staff and patients within the hospital. So there's a bit of a juggling act to be done, and we'll be considering that in terms of resource implications and sort of ideas around that at next week's Charitable Funds Committee. So I'll just stop there and happy to take any questions.
Thank you very much, Atul. I really welcome these updates, and I think, as you and I have agreed, we'll have charity committee updates more regularly now at both board and council of governors, and that was a great one. We've got something in the chat from Lee. Contract is signed, planning application in hand. Please around, very good, yeah. So we know that's all working, which is great. Are there any questions of Atul on what you've heard in his report? Strength to his arm, and we look forward to the next report. Thank you very much, Atul.
Thank you. Thank you.
And then we've got issues from the Governor's pre-meeting on item 11, and they've all been handled during the course of the meeting, with the exception of a point that Eddie mentioned, and actually that Lee has subsequently alluded to in the chat, that I think it's probably timely that we have another conversation at board soon about plans for site development before people thinking aloud amongst executive colleagues creates any concerns or what's the word, confusion amongst staff colleagues. So I think we'll take an action to bring that back to board soon. And the other one was a very good suggestion we had from Carol earlier about a governor handbook, which we're going to play back to Nicola as requested action on her return to the office. But other than that, I think we've covered the matters that were raised. So that concludes item 11 and brings us to item 12 of Governor feedback. And I know there's at least one item, because I know Margaret's got one for us, but if anyone else has, we'll come to you after Margaret.
Well, right. Two things very briefly. One of them is that Norman and myself met with Julie Clift and Vicky Devlin yesterday to discuss the Governor commentary for the quality account. So that's just to let you know that we have had that conversation, as it was agreed that we would do through involvement in engagement committee. So they've gone away to work that up into a form of words for the quality account. So hopefully that will capture everything that we think we've been doing over the last year. So that's an action done. And the other thing, yesterday I attended the Derbyshire Engagement Strategy the Derbyshire Engagement Committee meeting, and there was a lot of conversation, obviously, about the development of the system working, and they presented a very comprehensive engagement strategy about how they plan to engage with the public in the future, which we were able to comment on. And the other study that they'd undertaken was a study of how people use urgent treatment centres. And just really, so something that we need to bear in mind as we're developing our urgent care is that there is a lot of misunderstanding amongst the community about what urgent treatment centres are and what they can be used for. So any sort of information that we are producing, we need to be really clear about it. But it's a piece of work that's being done system-wide about reviewing provision for urgent treatment across the county. But it highlighted really, the confusion that reigns, not only in what they're called, but also what sort of functions they can be useful for. So I think I think they've realised that a lot more needs to be done to clarify that for the general public. So that's two bits of my.
Thank you very much, Margaret. Helpful to know the outcome of those meetings. And no doubt we'll hear more about the whole issue about nomenclature and communication about right paths of care in due course. Are there any other governors who need or would like to give feedback from how they've been or what they've been doing?
Yeah, just to say, I'm the representative on the urgent care and emergency department project board. There wasn't a meeting yesterday, and I don't really think I've got anything to add to the stakeholder meeting that we had at the beginning of the month. unless anybody's got any questions.
Certainly looking impressive, and as I gather, the external cladding is due to go on soon. So it's really getting quite exciting every time you walk past it. So a big thank you, actually, we should say. Well, we'll say it at the right time, but a thank you on account, Mike, for your contribution to that project. So it's
contributed very much.
Good. In terms of Governor update, all the other items on the agenda are either consent items or items for information. And believe it or not, talk about the year galloping by, our next meeting is on the 15th of June. But of course, there will be other occasions, I'm sure, in which we'll be together in different guises before then. But that's a date for your diary. So it just leaves us to review the meeting. How did we do today? If anybody would like to put up their hand and say how they felt today was, that would be good. Or if there's any comments people would like to put in the chat, please do. Can I go to you, please, first, Lynn?
Sorry, thank you, Helen. Yes, I just wanted to say that I think it's been a very good meeting. I think the information that we've had has been very clear and succinct. And I just wondered whether, because we're not meeting again until June, and I'm not going to be at that meeting because I shall be on holiday, whether there are any staff members here who won't be around in June. I'm thinking particularly about Zoe and Lee, and whether if they are going to be here in June, can I just say personally, because I won't be at that meeting, that I think you've done a brilliant job. And I've really enjoyed getting to know you in, a small sense, obviously. And I'd like to wish you the best for the future.
That's really lovely. Thank you very much, Lynn. And of course, we'd have another board meeting before Zoe and Lee depart, but not another Council of Governors meeting. So it's exactly the right time to express that vote of thanks and appreciation. So thank you for doing that, Lynn, and I'm sure that will be sentiments echoed across the Council of Governors, and there's some claps going up as we speak. But we'll be giving them a little do before they go, Lynn. Margaret, any reflections on the meeting?
No, I just want to sort of not exactly apologise on Nick's behalf, but just to explain to people that the papers did come out a little bit later than would be expected, because I think you've already mentioned that Nick's been off sick. So I'm sure she would have liked to have got them out sooner. And I certainly found that there was quite a lot of reading to get through. But it would have been nice if we'd had them a bit sooner, but it's circumstances. So yeah. And so that's the reason. So just to let you know that that's the case, and I hope Nikki's feeling better. I've not spoken to her recently, but I know she wasn't very well last time I spoke to her.
Absolutely, and still testing positive on day 7, poor girl. But I'm sure she'll be glad to get back. So listen, thank you all very much. My apologies that we've run over a little, but it was really good to be able to let some of those very important conversations earlier run their course. And thank you as ever for your best attentions, and see you soon.